Suresh Chandra, Dr. Qulub Hussain, Dr. Anuj Porwal. Anybody here? Mr. McLennan, why
I
don't
can
you
go right
begin?
into
Yes,
it. It's
please.
fine.
Yes.
So of the three talks, this is the one talk that I've actually done some of the research on. So I'm going to take some time on this. This is the use of carbon dioxide as a contrast agent in an effort to protect, renal function. All right. So again, disclosures. So here's the problem. Ideally, a fistula will be matured before it's needed, but what if it doesn't mature? And you have to figure out what's going on with this axis. We've talked a lot about using ultrasound to evaluate the stenosis, and you can probably do that with modern ultrasound quite a bit these days. But, this is, what if you get an arm like this? And this is unfair because this is my arm and I don't have a fistula, okay? But if you don't have that previous fistula, you've got to figure out what's going on in an arm like this or an arm like this where you have very small veins and what's going on. You want to be able to do your fistulogram to assess and treat the underlying stenosis, but if the patient's not yet on dialysis, what do you use? Take a step back and talk a little bit about contrast nephropathy. This is essentially the molecular backbone of all iodinated contrast agents. It's an aromatic ring with R groups on 3 and iodine groups on 3 of them that increases the stopping power of X-rays of this molecule by the high atomic weight of iodine, okay? The definition of nephropathy is an absolute increase in serum creatinine by 0.5 or an increase of 25%. It peaks typically at 3 to 5 days after contrast administration and generally will return back to baseline within 10 to 14 days. And that, is the ASN's, definition of contrast nephropathy. This is the Marin risk score approximation, looking at whether the patients are at risk for contrast-induced nephropathy. And you sort of take these integer scores of hypotension, intra-arterial blood pressure, CHF, age, anemia, diabetes, add them all up and look at where their risk scores are. And this is the risk of contrast-induced nephropathy. And the contrast media volume is a 1 point for each 100 cc's being used, okay? So when I do most of my interventional radiology procedures, even if I'm doing a TIPS, which is one of our most complicated procedures, I will use between 100 and 150 cc's of contrast in most circumstances. So I'm only adding a point or two to this. I've seen cardiologists who do heart caths and right heart caths who use 500 cc's of contrast. That's where you start running these numbers up and get these increased numbers with these increased risks of contrast nephropathy. So knowing your volume of contrast administered during your procedure is very, very important. So what were the alternatives? Back in the old days when I was first doing this stuff, we looked at gadolinium as an alternative. Why were we doing this? Well, it was exclusively excreted by the kidneys. If the GFR was less than 10 mils per minute, there was a 5-fold increase in the clearance rate. So they recommended 3 hemodialysis sessions afterwards. The first one removed 65% of the gadolinium, the second one 82%, and the third removed about 90% of the gado that was circulating in it. And because we thought of gadolinium as an alternative contrast agent, we started using it quite a bit. And we ended up with the syndrome of NFS, which sclerosed the skin and caused a lot of complications. And that is mostly in the use of the triple recommended dose of gadolinium. Gadolinium is recommended at no more than 20 cc, total, 20 milligrams total, and we were using 60 milligrams in these patients. But this is a gadolinium contrast angiogram of a renal transplant arteriogram. And the reason it works as a contrast agent is it's got its atomic number of 53 and its K edge of 33 kiloelectron volts, which stops the X-rays from going through it and makes a very nice contrast edge. So that's iodine, and if you look at the KEV here, it's very similar. So it looks a lot like contrast. So carbon dioxide has been used in medicine since 1914. Its first medical use was in 1914. Its first use as an intravenous contrast agent was in the 1950s. It was used for peripheral vascular imaging in 1970s. In the 80s, with digital subtraction angiography, it became much easier to use, and CO2 injectors were developed and things like that. It is non-toxic, it is non-allergenic, it is completely eliminated in a single pass in the lungs. So you inject it in the veins or you inject it in the arteries, it'll go through the circulatory system, and the first time it hits the lungs, it is exhaled. It is 20 times more soluble than oxygen in blood. So when you're using CO2, you need to make sure you have a pure collection of CO2 that you're injecting, because that's what's going to get miscible in the blood and get excreted. It allows very low pressure injections, and it is completely radiolucent. So negative contrast is equivalent to positive contrast. These are some of the pictures that you will get with CO2. So it's eliminated in one pass, and this is a pulmonary artery. You see as it gets into the pulmonary artery, it starts to break up into little pieces. But you can get a pretty reasonable, venogram here of the central veins. You can see a stenosis of the SVC. It can give you the information that you want to see. So there is some animal data. In excessive volumes in very short times, 1 to 5 liters of CO2 in 1 to 3 minutes can kill an animal. That's replacing the blood volume of the animal. I don't care what you give that animal in that volume, in that time, it'll kill him, okay? There's really no evidence of specific renal excretion after injection of 10 times the normal dose selective into 14 animals. Mild ATN was seen in one of the kidneys, which was vertically positioned. So CO2 will tend to rise in the body. If you put it up, the gas will collect there and can prohibit blood from going into it. They saw significant neurological deficits in 20 rats because the blood-brain barrier was disrupted, but there were no neurological deficits in 10 animals when the arch and selective vertebrals and carotids were injected with CO2. So that was sort of the Hawkins animal safety data that was done in the early 90s. How accurate is it? This is a study I did when I was a research fellow in Indiana. We looked at arterial measurements of the iliac arteries and aorta, both with iodinated contrast and carbon dioxide, and we compared it to IVUS as the standard. And there was absolutely no difference in the estimation of diameter between the two. The CO2 was injected with the angiodynamic CO2 injector, which is a device that will never be available for use in the United States because the FDA was going to require angiodynamics to approve CO2 as a drug in order to sell the injector. What about in fistulograms and venograms? Well, 94 Ehrman published in 32 patients. There was no difference in estimating diameter stenosis using CO2 or iodinated contrast. In 2006, Hay looked at 22 patients, had a 97% sensitivity, 85% specificity in using carbon dioxide for fistulograms. Technique, this is a fluid management system. It's used by all angiography systems. It's really from flushing fluids. There's a side arm that goes into a bag here. This is a one-way valve. This is a three-way stopcock right here with a one-way valve right here. So you fill up this bag with CO2 3 times and expel it 3 times. You can prime this tubing with CO2 using this syringe 3 times, and then you flush everything through. So this is an example of what you get. I'm going to take a little extra time since I saved some on the first one. Come on, you should play. I'll let you guys do it. You just basically see this very brief white stripe. So that's what you get on your angiography. When you do this in digital subtraction, this is what you see in that same fistulogram, okay? So you can sort of see the stenosis there. You can see the central stenosis. Breathing becomes an issue, so you really have to have them hold their breaths real well. This is a fistulogram done here with the stenosis right there. So in summary, CO2 can be used as a contrast. It's eliminated first pass in the lungs. The contrast detail is a little bit worse, so you should be able to recognize that as a CO2 fistulogram or venogram. Diameter and stenosis accuracy is equivalent to contrast, so it can be used.